see it with a CT scan, but when you're first assessing the patient, um, you can't see the injury. So what you have to do is you have to listen to what the patient is saying. So if the patient is saying things that suggest that they have a memory problem, then you think it's the hippocampus, right? If you think the patient is having, perceptual disturbances, like they interpret reality different than you, or their reality is so different that you can't understand how they came to that conclusion, that may be the prefrontal cortex. If they start having like impulse control issues, attention to concentration issues, planning problems, then that may be the frontal lobe. So even though you can't see the brain, for a person who's experienced a significant head injury, you can sort of listen to them and examine them to sort of see the areas that are most likely impacted. If you understand the networking and the blood supply and things and what that area is responsible for, then you'll probably get a good idea of what you're going to use as medications to help treat. So, for example, if the patient's hippocampus is malfunctioning or is damaged and they're having difficulty with memory, of course, you want to use the medication to help the patient with memory issues like Aricept, memory medications, right? If the patient is having rage attacks, secondary to damage in their temporal lobe and things like that, something similar to temporal lobe epilepsy or word finding, speaking difficulties, then you think that's the temporal lobe. And you may want to put the patient on something like a mood stable, like Depakote, to decrease all of that seizure-like activity in that in the temporal lobe that's creating all the agitation and aggressiveness. If their frontal lobe is hypoactive and they can't pay attention to concentrate, you may want to start a stimulant, right? If they're having psychotic symptoms like hallucinations, delusional, disorganized behavior, you may want to you may want to prescribe an antipsychotic because they would block all those dopamine pathways, right? So with a diffuse traumatic brain injury, that means, imagine like a motorcycle accident, right? Inside the brain is a sponge and it batters back and forth inside this cage, creating coup and then contra coup injuries, coup and then contra coup. Coup when it hits forward, when the brain hits something, the skull hits something, the brain moves forward and hit the anterior wall, anterior surface, the anterior part of the brain in this coup injury. And just like the sponge, it is that wave ripple back and it can hit the posterior aspect of the skull called a contra coup injury. And you can get injuries flipping over on the motorcycle, rotational stalk injuries, hyperextension, overextension, rotational injuries. These rotational injuries could be very damaging because you're stressing these structures that are right there at the stalk. So you're stretching all of these structures and you're interfering with these huge bundles of fibers that go and do things. And so those rotational like injuries can be very devastating, right? So what we're going to do here is let me search. Let me search something. Let me see. What am I searching for? Okay. Let me draw these things. Okay. Let me go ahead and search, explain. Explain the assessment. Okay, explain the assessment and treatment of diffuse traumatic brain injury. Oh my. Let me see what they have here. Oh, let me go through this first. Pretty good example. Yep. Pretty good example here. See, I get all mine for free. I just go in and get out. Go in and get out free. Okay, here's the wall. Okay, Here's the brain pushing forward and hitting the internal surface of the skull. And just like gelatin, it pushes, comes back, and you can get a second injury when the sponge hits the back injury of the skull. Now look at all of these layers here that becomes disrupted. Look, this is the axon shear here. At that differentiation between the gray and white matter here, the severing can occur at this point, severing the neuron in half, right? This is very dangerous, and it can occur in multiple locations. Why is this dangerous? Then the damage and the death of the cell leads to a loss of all of the content in that space. And so you get the release of all of these molecular molecules in that place and all of in this space, and all of these things do things. They're all active. So the content inside of the cell is considered more toxic outside of the cell. You don't want all those things outside of the cell because they're very active. You have a factory with no windows and no doors, right? And remember the rotational stalk injury? Yeah, that shearing effect, that shearing effect can be very dangerous. Let's see here. Okay, let me. This is great. Wow. Hey, look at this. It's great. Diffuse axonal brain injury. Hey, all right. Injury attorneys. You mean that I got to get my reference material from injuries attorneys? No, I'm not doing this. I'm not getting my material from an injury attorney. No, the stuff is nice. His or her stuff is really nice. Okay. Anatomical justice. Is this another legal site? Man. Okay, you'll see anatomical justice. Okay. Whiplash. Here, subdural hematoma. Right? A subdural. So this gray part, okay, yeah, the gray part there is the subdural hematoma. Look, here's your dura, brain, the skull, the bridging brains. Can't really see them that well, but it serves its purpose. Look here, you have subdural hematoma. So the effects of diffuse traumatic brain injury on the brain cells. Great. Axonal shearing occurs during hyperextension or hyperflexion injuries. Okay, shearing. Axon terminals pulled away from synaptic junctions. Wow. Wow. That's the first time I've heard of that one. Of course, the axon, then the axon terminals. Okay. And here's the shearing. Oh, okay. They say retraction ball here. Necrosis of the cell body and dendrites. Yeah. And then when the cells die, they're not replaced, right? Then there's an entire process that takes place after the cell dies. In order to clean up all of this, you have your immune system that picks up the damage, and then it starts to recruit it recruits an inflammatory response, which recruits more of the white blood cells to sort of help manage this thing, help clean this place up. In order to increase the inflammation, it has to make the blood-brain barriers porous. And because the blood-brain barrier are porous, now you get the state of sort of confusion and sort of like a diminishing storm, difficulty focusing, difficulty concentrating, difficulty thinking, because that inflammation, the inflammation interferes with how all the networks function, because the inflammation makes the blood-brain barriers porous. The blood-brain barrier is supposed to be semi-porous. It's a semi-permeable membrane, meaning it only lets specific items through. However, after the inflammatory response to an injury such as this, it must increase the inflammation in order to get the immune system there, in order for the immune system to start to react to this event. And the inflammation itself causes dysfunction with the neighboring circuits around it. And the inflammation itself can also promote and encourage more brain cell death. So the death of the cell leads to the death of the cell leads to worsening inflammation, and that inflammatory response, although it's there to help you, it also causes damages also. This is a tough situation to be in, you know. Anatomical justice. Let me get off this page. Why do the attorneys have better diagrams than the doctors? Let me look here. Oh, these are for sale. Those are, I don't, let me get off the attorney website. All right, so here. Okay, then let me look here. What is this? Classification of traumatic brain injury. Okay. Okay, types of brain injury. Diffuse, and this I'm talking about here. Focal, right? Diffuse, a concussion. Remember a football, a helmet, a foot getting knocked unconscious with football, or falling off a motorcycle with a helmet, right? Diffuse axonal industry, the blast, right? Abusive head trauma, shaken baby syndrome. Yeah, head trauma, shaken baby syndrome, a blast, a diffuse axonal blood, diffuse axonal injury, and a concussion. So these are all the different things that can create a diffuse traumatic brain injury here. And then focal, like contusion, get hit on the head with a ball, penetrating gunshot wound, epidural, right? Then you can get a hematoma located in the epidural space, the subarachnoid space, or subdural. So, but these are so a hematoma could create a focal injury because it can still lead damage to the tissue, like intravesicular hematoma, also intracerebral, intraparenchymal. And so these are all the focal subtypes of a diffuse traumatic brain injury. Yeah, this thing is helpful. Okay, let me see here. Okay, here. Diffuse traumatic brain injury, especially diffuse traumatic axonal injury, is assessed by monitoring vital signs such as a Glasgow Coma scale. Oop, hold on one second. Telemarketer. Okay, yeah, the Glasgow Coma scale, right? Performing neurological evaluation and using images like CT scan or MRI to check for widespread damage. And you want to see inflammation, right? Treatment focuses on preventing secondary injury by optimizing oxygen levels, maintaining blood pressure, and managing intracranial pressure. Long-term care involves a multidisciplinary team of specialists providing physical, occupational, speech, psychological, and cognitive therapy to help the person regain function and return to a normal community. Just look at these areas. Long-term care, multidiscipline, right? Specialists, okay. Physical therapy, getting in shape. Occupational therapy, learning how to work around the house. Occupational therapy, learning how to get around the house, speech therapy, because it can be in the area of age for speech. Psychological, right? Because it can be in that prefrontal cortex, affect your perception of things. Cognitive, it can be in your frontal lobe. And so this multidisciplinary team will focus on the different aspects of the person's care. Let's look here, the assessment, the initial pre-hospital evaluation session, of course, vital signs, Look, Glasgow Coma score, a score out of 15 to assess the level of consciousness. Now, the higher the Glasgow Coma score, the likely the severity, the severity of the symptoms associated with the diffuse traumatic brain injury. So, if a patient had like memory loss, like if they had a diffuse traumatic brain injury, and you're talking to them a month later, you say, okay, well, do you remember the events that led up to the accident? I don't remember. Retrograde amnesia. Well, do you remember what happened when you woke up in the hospital? Yeah, I woke up in the hospital. My mom and pop was there, and we were talking about things and everything like that. So no anterior grade amnesia. So with the diffuse traumatic brain injury, look for the retrograde amnesia. Did they remember things before the accident, or the anterior grade afterwards? And so, great. Next, pupil examination, pupil dilation. See if those tracks are functioning well. Get the patient history, gather information about the injury, and if consciousness was lost. Okay. Medical evaluation, so of course, neural exam, CT scan most likely, blood tests. Right. If they come in confused or agitated, you're going to need blood tests to see what's going on. Right. Treatment, acute and supportive management, and then long-term rehab. Look, oxygen and ventilation. Stabilize the blood pressure, prevent other problems by managing everything correctly, right? So you don't want a fever, you don't want high blood sugar, things like that, Long-term stability. Again, the multidisciplinary treatment approach, physical therapy, right? Occupational, getting around the house, speech, communication, cognitive, alertness, awareness, psychological counseling, support, vocational counseling, basically start getting being able to assess the person's skills and sort of help him get back to work. Here, now let me see. Explain the okay, let me see if they, of course, the treatment is going to be whatever's in front of you. Basically, you're going to have to put together a combination of medication to make things work right. Medications for diffuse traumatic brain injury target specific symptom complications, including anticonvulsants for seizures, particularly if it's in more of the temporal lobe where there's intense anger, diuretics to reduce intracranial pressure, pain relievers and headaches, antidepressant if they're very depressed, anti-anxiety agents. But with diffuse traumatic brain injury, I recommend try to stay away from narcotics because they have difficulty controlling the impulses. So if they start using a narcotic, then they may not be able to stop because they don't have the frontal lobe power to suppress that impulses. Does that make sense? And stimulus to improve alertness and focus. Other medications include muscle relaxants, anticoagulants, and medications like amantadine for cognitive and behavior issues. Okay. Medications for acute symptoms, such as medications for acute symptoms and complications. Diuretics. Leave that to the other team. You have your anticonvulsants. I prefer Depakote. Anticoagulants. We leave that to the medical team. Osmotic agents, the medical team. Management long term. Yep. Same thing. Okay. Let me look here. The choice of intensity of medication depends on the type of severity. Let me look and see if they come in anything on the severity of TBIs. What type of TBIs are medications? Medications administered for traumatic brain injury depends upon the type of injury, its severity and results. Functional impairment. Medications also vary on the stage of treatment, which includes acute phase of treatment immediately after the injury and a long-term management complication of chronic symptoms. Okay, so same thing, osmotic agents decrease the height of pressure, anti-convulsant, make sure their electrolytes are bound. Now, look at this, NMDA receptor antagonist. NMDA is a type of glutamate receptor, and glutamate is excitatory. So they want to not use anything that's going to excite glutamate because that's going to make it more hyper. We want to go with, reduce it. So barbiturates, I wouldn't use those. Long-term managed stimulants, because you may need to stimulate the frontal lobe. If the frontal lobe is in hyper, if the frontal lobe, just like if the frontal lobe is damaged and it's not as active, then you have less executive functioning symptoms. You become more inattentive and easily distracted. That's why in children with ADHD, we give them stimulants to stimulate the frontal lobe, not to stimulate the whole body, to stimulate the frontal lobe to become more active. So the frontal lobe processes more information, and therefore the patient reacts because they're processing more information. So that's what the stimulus is for. Now, remember, dopamine antagonists, remember the diffuse traumatic brain injury can damage the major pathways. If you get damage to the mesocortical pathway, it's going to bounce up and down. When that mesocortical pathway bounces up, you're going to get positive symptoms. When it bounces down, when it becomes hypoactive, you get negative symptoms. And so during the day, if the diffuse traumatic brain injury, let me show you what I'm talking about here. Okay, mesocortical pathway. Let's look here. This pathway here, come on, give me for free. Come on. Give it for free, yeah. Y'all can get it for free. It's educational purposes. So this is the major nerve bundle in your brain called your mesocortical pathway that's primarily responsible for the symptoms of autism and schizophrenia. If the diffuse traumatic brain injury damaged this root at the stalk, then the entire network becomes unstable, meaning it's no longer regulated, meaning there are times when the network becomes hyperactive. When this mesocortical pathway becomes hyperactive, you get positive symptoms of schizophrenia. When it becomes hypoactive, you get negative symptoms. And so an injury, diffuse traumatic brain injury, can switch this network on and off. And so the patient presents agitated, psychotic, then withdrawn and apathetic and avoidant and things like that. Now, that's just that pathway. And look how far it extends all the way up here to the frontal lobe. This pathway right here, the mesolimbic pathway, is the pathway of target for all the drugs of abuse. Hyperactivity in this creates the intoxication that every cocaine addict, person who's addicted to cocaine uses. So the addiction to cocaine is secondary to the need to keep activating this mesocortical pathway. Now, during drug withdrawal or cocaine withdrawals, they typically have the exact opposite symptoms. The fatigue, the anhedonia, decreased interest, decreased motivation. You get injury to this mesolimbic pathway, it'll be hard for the person to experience your pleasure, dysphoria. They'll keep popping back and forth, happy, sad, it's just to be a mess. And so you can see how the diffuse traumatic brain injury damaging these major nerve bundles can create complications due to overactivity and then suddenly hypo or underactivity. And take that throughout all the networks in the brain. And there you see the complexity in treating diffuse traumatic brain injury. So what I do is sort of like look at the area of the brains that's not working well. If it's not the hippocampus, if the memory is not working well, then we need to work on the memory. Work on the hippocampus. If their perception is off, we need to work on this mesocortical pathway. If they seem like they're withdrawn, hypoactive, no interest, motivation, we need to pump up the mesolimbic pathway. So I sort of look at these different parts of the brain and the pathways to sort of try to figure out a way to stabilize all of this symptomatology, right? And so things like Depakote mood stabilizers are always used first, and then try to target the hippocampus with things like acetylcholine and increase the acetylcholine in those parts of the brain. I think that's all I want to say here about diffuse traumatic brain injury. And if you have any questions or anything like that, please feel free to put them in the comment. If not, yeah, it's a pleasure talking to you. Take care, guys. Read out. Ciao. Hey guys, how's it going? Reed here. We're about to have a very interesting discussion. A very interesting discussion on lithium and the signal transduction cascade. This is part two. Go back to the previous podcast I did on the signal transduction cascade. And from there, you'll see how the signal transduction cascade is the mechanism that transfers the signal from the receptor to the cell body. The ligand binds the receptor on the outside surface that goes through a signal transduction cascade process, and then the product of that is sent to the cell body so the cell body can produce a response, which is typically a product that can likely be exported out the cell or placed on a cell membrane, right? So it's important to know, and this is very important because what happens is that when you are treating patients and they have a partial response, when they have a partial response, um, that implies that you blocked all the receptors on the postsynaptic receptor. You blocked the majority of the receptors, and you're not getting the response you want. The problem is that it may be problems within the it may be problems within the signal transduction cascade in and of itself. And guess what helps with that? Lithium. Lithium helps with the steps of the signal transduction cascade by making it work better, it perform better, and it increases more stability for the entire cell. So we're going to go through that. Lithium is a very, a very important medication. Okay, let me see here. Okay, let me see here. I got hot sauce and fish. I got fried fish and hot sauce in the back of my throat. Jeez. Fried fish and hot sauce. Catfish nuggets and hot sauce. Okay. Explain. Explain the role of lithium in the signal transduction cascade. Okay. Lithium, widely used as a mood stabilizer in bipolar disorders, has multiple biochemical effects on signal transduction cascades in the brain. Its therapeutic effects range from modulating intracellular signaling rather than from direct effect on the neurotransmitter receptors, right? Its focus is not the receptor, it's the activities that happens after receptor bound. Hold on 1 second. Jesus, sorry about that. I got catfish granules in the back of my throat. Okay, so let's see here. Okay, so here, it doesn't bind directly. The effects is not directly on the receptor, the neurotransmitter receptors. It modulates the intracellular signaling, the things that happens inside the cell. Overview, what lithium does in signal transduction. Signal transduction cascades are how cells convert an external signal, like a neurotransmitter binding on a receptor, to an internal response, such as a gene expression or ion channel charges. Lithium acts downstream on neurotransmitter receptors, meaning it influences second messenger systems, especially the phosphoinositol system um, basically dopaminergic neurons. Okay, the pathway is crucial in the role of the brain's reward systems, motivations, reinforcement, and learning. Okay, here, let's see. So let me look at here. Let's look at the pathway here. That's too far. Okay. So here, from this area here on up here, yeah, this is it. That's it. So let me see receptors profile. So let's look at the receptor profile for it. Okay. So on this mesolimbic, hello everybody, Dr. Reed here. And so the name of this discussion is about diffuse traumatic brain injury. And we're going to discuss how to identify, how to assess, and how to document, and how to treat diffuse traumatic brain injuries. Now, diffuse traumatic brain injuries are a challenge in and of themselves. Why? The brain is encased in this bony cavern, and you can't see it, right? Well, you can see it with a CT scan, but when you're first assessing the patient, you can't see the injury. So what you have to do is you have to listen to what the patient is saying. So if the patient is saying things that suggest that they have a memory problem, then you think it's the hippocampus, right? If you think the patient is having, perceptual disturbances, like they interpret reality different than you, or their reality is so different that you can't understand how they came to that conclusion, that may be the prefrontal cortex. If they start having like impulse control issues, attention to concentration issues, planning problems, then that may be the frontal lobe. So even though you can't see the brain, for a person who's experienced a significant head injury, you can sort of listen to them and examine them to sort of see the areas that are most likely impacted. If you understand the networking and the blood supply and things and what that area is responsible for, then you'll probably get a good idea of what you're going to use as medications to help treat. So for example, if the patient's hippocampus is malfunctioning or is damaged and they're having difficulty with memory, of course you want to use the medication to help the patient with memory issues, like Aricept, memory medications, right? If the patient is having rage attacks secondary to damage in their temporal lobe and things like that, something similar to temporal lobe epilepsy or word finding, speaking difficulties, then you think that's the temporal lobe. And you may want to put the patient on something like a mood stable, like that. Read. Hey guys, how's it going? Reed here. We're about to have a very interesting discussion. On lithium and the signal transduction cascade. This is part 2. Go back to the previous podcast I did on the signal transduction cascade. And from there, you'll see how the signal transduction cascade is the mechanism that transfers the signal from the receptor to the cell body. The ligand binds the receptor on the outside surface that goes through a signal transduction cascade process, and then the product of that is sent to the cell body so the cell body can produce a response, which is typically a product that can likely be exported out the cell or placed on a cell membrane, right? So it's important to know And this is very important because what happens is that when you are treating patients and they have a partial response, when they have a partial response, um, that implies that you blocked all the receptors on the postsynaptic receptor. You blocked the majority of the receptors, and you're not getting the response you want. The problem is that it may be problems within the it may be problems within the signal transduction cascade in and of itself. And guess what helps with that? Lithium. Lithium helps with the steps of the signal transduction cascade by making it work better, it perform better, and it increases more stability for the entire cell. So we're going to go through that. Lithium is a very important medication. Okay, let me see here. I got hot sauce and fish. I got fried fish and hot sauce in the back of my throat. Jeez. Fried fish and hot sauce. Catfish nuggets and hot sauce. Okay. Explain. Explain the role of lithium in the signal transduction cascade. Okay. Lithium, widely used as a mood stabilizer in bipolar disorders, has multiple biochemical effects on signal transduction cascades in the brain. Its therapeutic effects range from modulating intracellular signaling rather than from direct effect on the neurotransmitter receptors, right? Its focus is not the receptor, it's the activities that happens after receptor bound. Hold on 1 second. Jesus, sorry about that. I got catfish granules in the back of my throat. Okay, so let's see here. Okay, so here, it doesn't bind directly. The effects is not directly on the receptor, the neurotransmitter receptors. It modulates the intracellular signaling, the things that happens inside the cell. Overview, what lithium does in signal transduction. Signal transduction cascades are how cells convert an external signal, like a neurotransmitter binding on a receptor, to an internal response, such as a gene expression or ion channel charges. Lithium acts downstream on neurotransmitter receptors, meaning it influences second messenger systems, especially the phosphoinositol system and the G protein signal killing cascades. So look, lithium acts downstream of the neurotransmitter receptors, right? It influences second messenger systems. One, the phosphoinositol system, and two, the G protein cascade system. Key targets and pathways. Inhibition of inositol monophosphate, right? Modulation of G protein coupled receptors, right? And then C here, the effects on protein kinase pathways. Great. Inhibition of inositol phosphatase Now, this is amazing. Basically, it prevents the um, what? It prevents the recruitment of PIP1 so that you don't have enough PIP1 to make PIP3. Very interesting. In a normal pathway, the neurotransmitter binds the G protein and that activates phospholipase C, which cleaves PIP2. That produces PIP3 and DIG. Now, PIP3 releases intracellular calcium. Right now, so remember, PIP2 is broken down into PIP3 and DAG. Right? Now, this IP3 causes the release of intracellular calcium. Now, in sort of recycling, if we want to recycle IP, make more IP3, then we take inositol and we reuse it to make PIP2. Oh, wow. So PIP2 plus inositol makes PIP3 plus inositol makes PIP2, as opposed and PIP2. Okay. Skip that. Okay. So lithium roles. Lithium inhibits inositol monophosphatase and inositol polyphosphatase 1 phosphatase and blocks the recycling of inositol. So it blocks the recycling inositol. Okay, so you need inositol in order to get PIP2 back to PIP3 back to PIP2. Like here's PIP3 right here, which is that, and you want to get back to PIP2, so you need inositol in order to get to PIP2, then it's cleaved again. Yeah. So lithium blocks the recycling of inositol. Okay, this leads to the depletion of PIP2, right? Right, PIP2 is cleaved there. So it leads to the depletion of PIP2, reducing signaling through G coupling receptors. So it decreases the production of PIP2 and depletes the production of PIP2, and therefore it reduces the signaling. Okay, great. That's the feedback. Okay. Reduced overactive signaling in circuits linked to mood dysregulation. This is known as an inositol depletion hypothesis. It's really interesting. So, yeah. So basically depleting inositol. Okay. Modulation of G protein coupled receptors. Okay. Lithium interferes with G protein cycling, particularly G1 and GS proteins. So lithium interferes with G protein cycling. It tends to reduce adenylate cyclase activity, lowering to lower CM peak levels. So it reduces adenylate cyclase activity, lowering CMP levels. This modulates signaling in dopamine, serotonin, and norepinephrine systems. Okay, so basically it interferes with G protein cycling and reduce adenylate cyclase activity, so less cyclic AMP, and so nothing's going to run as well. You basically turn the whole cell down by reducing the cyclic AMP. Stabilization of mood via dampening excessive excitatory transmitter. So basically it results in stabilization of mood via dampening excessive excitatory neurotransmitter. We're talking about excessive excitatory neurotransmitter. Okay, great. Next, effects on protein kinase pathways. Lithium inhibits glycogen synthase 3, a key enzyme in many cell signaling, including with insulin neurotropic signaling. Normal function, GSK3 phosphorylates various transcription and cytokeratal proteins, often inhibiting growth and signal and plasticity signals. Lithium directly inhibits GSK3 by competing with magnesium binding sites. The results increase neural protection and synaptic plasticity, promotes BNDF signaling, and supports mood stabilization neurogenesis. Yeah, so it inhibits glycogen synthase 3 And this results in increased neuroprotective synaptic plasticity, promotes brain-derived neurotropic factor, and supports mood stabilization and neurogenesis. Yeah. Summary of effects in the cascade. So, okay, this is okay. Let me see here. The okay, the inositol pathway. Basically, lithium inhibits inositol recycling, and that decreases intracellular calcium signaling, right? In the cyclic AMP pathway, it reduces cyclic AMP production, and it results in less overstimulation of receptors. It targets the GSK3 pathway. It inhibits GSK3, and that leads to more neurotropic and neuroprotective signaling. And then here, this Krebs and brain-derived neurotropic factor. It enhances via GSK3 inhibition. So you inhibit this, you get an enhancement of these, and this increases neuroplasticity and mood stability. You know, lithium is a very, very important medication to use, and so I think you should probably consider it when you're managing your patients. Um, and I think that's all I have for now. I think it's a pretty consistent discussion, but I think we got it. So, please feel free to like, subscribe, and share. And And this discussion is mainly about how these narcissistic networks distort reality. And these networks are so powerful that they can subject us to living in realities that we don't want. You know, you ever had the experience of not getting the job you wanted, or not getting the position you wanted? You know, you ever think about how your life is stagnated, while other people, the people included in the club, they tend to just go on like a rocket. They jump steps without having any issues at all, and they seem to do it naturally. And why are you having all these troubles, all these problems? After 20 years of working in your profession, why aren't you at the top? Why aren't you at the top when other people pass you by? Yeah, that's because the narcissistic networks around you taking all the resources for themselves, and they don't have anything left for you, and they're never going to give you anything. You better understand that. So this is Reed here. How's it going, everybody? Hey guys, Reed here. Today we're going to have a very interesting conversation about lithium, right? Lithium is an amazing medication. It's one of those medications that has a bad rep, but it's used so many times, and it's used in some of the most complicated cases. But lithium is an amazing medication, and I think you should know the mechanism of it so you can see how much benefit it can have. Now, lithium is an anti-manic medication. It's an anti-manic agent, and lithium is an ion. It's not a compound, so it doesn't need to be metabolized. It simply needs to be secreted, like lithium, salt, sodium, potassium, all of those, right? So lithium plays a very important role with augmentation. Like if you have a patient that's let's say you have a patient who's you're treating for depression, and you have the person on an SSRI. You start the person on the SSRI, and you get a little response. You increase it, you may get a little bit more response. You increase it more to the maximum, something like that. You may not get as much of a response. What do you do there? Well, you want to see about using lithium. May consider using lithium in that supplementation situation as an augmentation strategy, right? And the reason why is this. Let me show you. Let me sort of show you how this sort of works. Okay, what am I looking for? Let me give you an image of the image of synaptic cleft. Okay, let's see. Let me pull up this one here. Okay. Here's the presynaptic neuron right here. Here's the postsynaptic neuron right here. Presynaptic, postsynaptic. Okay, now here, okay, great. Here, the ligand is binding the receptor. And after the ligand binds the receptor, then there's a 3D configuration change in the receptor, right? And that leads to the signal transduction cascade that sends the message to the cell body on what we want, what this ligand here, this molecule is intending to have the cell produce. So this molecule is binding to the receptor to translate a signal to the cell body to produce more of X, right? In the situation that I described where the person is on an antidepressant or something like that, and we have basically all the receptors bound, but there's no response, it could be that the signal transduction cascade, the inner signal, is malfunctioning, right? So we can not only get one, so we think that once the ligand is bound to the receptor and when the receptor is activated, we think that we're going to get a response for the cell. But what happens is the mechanism that transfers the signal could be disrupted, and that's what lithium is for, right? So you're giving someone medications and the receptors are not working. So you give them lithium. Lithium works on that signal transduction cascade after the reception. And that's what we're going after the receptor. And this is what we're going to look at the signal transduction here. I hope you got that. Okay. So let's look here. Let me see. Okay, explain the signal transduction cascade when ligands bind G protein receptors. Okay, here's the signal transduction cascade. Let me see if before I go here, let me just try to pull up an image of the signal transduction cascade so you know what I'm talking about. Signal transduction cascade, let me see here. Okay, well, man, they doing this in Khan Academy? Okay, here. All right, and so here are the here's example here. Here's this this is the postsynaptic receptor. It could be the presynaptic receptor, but here are the ligands, right? They're binding the proteins, and this is resulting in a series of reactions that release two subunits, and those subunits become active and start doing here. But I never remember. I have to go back and always remember the things here, but but you can see what's happening here. Oh, okay. So this is interesting that this, I never, somehow, I never placed the signal transduction cascade within the plasma membrane. I thought it was inside the, okay, no, oh no, this is the nucleus. Okay, yeah, okay. No, here's the, it is, right, it's the plasma membrane here. Here's the cell, this is the nucleus here. So here's the receptors. This is the signal transduction cascade that go ahead and sends the signal here, phosphorylation. So let me go ahead and go through this. I think I have a better example than this one. But you see what I'm saying? This, when you can get to a certain point where this pathway isn't really working well, and this is one of the reasons why you want to sort of use lithium. Look, here's the signal here, here's the receptor, here's the conformational. It starts off with this, then it's conforming to this, then it's conforming to that, and then it's going to send this message to the cell body, and the cell body is going to produce something and then have it exported out of the cell body. So this is a signal transduction pathway I'm talking about. I don't think it's very necessary to get into. I don't even remember all the, I look at it for years and everything, just don't stick in the memory. But this is the pathway here, and this is what you want to use lithium to sort of help work on if you are not getting a good response. Okay, so I think I got that. Okay, here, explain the signal transduction cascade when ligand binds G protein receptors. Excellent questions. Let's break down the signal transduction cascade that occurs when a ligand binds to G protein couple receptors. Now, I specifically put G protein couple receptors, not ionotropic receptors that turn on and off, like those gate controlled and ionic controlled, not those. Those just turn on and off and deal with the currents that's coming across to maintain that action potential, right? But I'm talking about the G proteins that are there to take the signal so that you can produce things from the cell. Okay, so my search was specifically for those. G protein couple receptors are membrane proteins that convert extracellular signals like hormones or neurotransmitters into intracellular signals via G proteins and second messengers. You got me now? Right. The key steps are the ligand binds to a G protein receptor. The G protein receptor activates a G protein, right? So you have the G protein receptors, and it has two subunits that are inactive when it's bound to it. The configurational change results in release of the two subunits, and they go on and start doing their thing, right? Okay, so G protein activates or inhibit an effector enzyme or channels. Right, okay, yeah, see, the G protein can turn off or turn on these ligand-gated or ion channels, right? Ion channels here. And then also this signal transduction cascade typically results in the cell producing something that's going to be exported out for the cell's functioning. Right? Then you get a cellular response, then the signal is terminated. Okay, those are the steps. So here, that's step one. Step two, receptor ligand binding. The ligand signal molecules such as epinephrine, dopamine, serotonin, or acetylcholine bind to extracellular domain of the G protein. Okay, the ligand binds. The receptor changes shape. That means there's a conformational change. The conformational shifts alters the cytoplasmic side of the receptor, allowing it to interact with a nearby heterometric meric G protein. Yep. Let me show you this. Let's go through this again. The conformational shift alters the cytoplasmic side of the receptor. So remember, the ligand is on the extracellular. It binds to the extracellular domain, right? And then the conformation alters the cytoplasmic side of the receptor, allowing it to interact with their nearby heterometric G protein, right? Okay. Activation of the G protein. G proteins are heterotrimers with three subunits alpha, beta, gamma. Okay. In the inactive state, the alpha subunit is bound to GDP. When the GRAC protein is activated, it acts as a G-guanine nucleotide exchange factor, causing the alpha unit to exchange GDP with GTP for GTP. This activates the G protein. The alpha subunit dissociated from the beta dimer, and both can signal independently. This is the G protein right here, activation. Yeah, look, effector activation. Yep. The active G alpha or the gamma or beta complex interacts with downstream effector proteins, such as GS stimulatory, G inhibitory, phospholipase, these channels. Okay. Second messenger generation. Effector enzymes create second messengers, which amplify the signal. Effector enzymes create second messengers, right? So if you have a ligand that's going to activate the receptor, then the second messengers is going to amplify that signal, what they want. Adenylate cyclase produces CMP, which activates protein kinase A. Phospholipase C splits into PIP2. PIP3 phosphate inositol triphosphate triggers calcium release from the endoplasmic reticulum. DAG DAG activates protein kinase C, and then ion channels alter membrane potential and carry in calcium entry. Next, you also have a cellular response. Activates kinases, phosphorylate target proteins. I'm sorry. Okay, let me slow down. Okay, this is the second messenger generation, okay? And then here's how the cell responds. Activated kinases, such as phosphorylate target proteins, the kinases phosphorylate target proteins, and this alters the enzyme activities. Again, gene transcription, ion channel conductions, and the cellular metabolism, secretion, or contraction, etc. Now, see, 6 is the point where the cell actually responds. So with all of these kinases activated, you get phosphorylation of all of those target proteins. And as a result, it results in a change in enzyme activity, a change in gene transcription. These are the new genes that we want to have expressed. a change in ion channel conductance, meaning changing the action potential. And this results in metabolizing, producing, and taking in other substances from the cell. Okay. Next, signal transformation. To prevent overactivation, the G alpha subunit hydrolyzes GTP to GDP. And via intrinsic GTP's activity also is often accelerated by RGS proteins. Right, right. Okay, so the alpha subunit has an intrinsic GDPase activity, and so therefore it's going when it's released, it's going to convert GTP to GDP and therefore deactivate itself. Alpha GDP reassociates with the gamma and it activates the G protein, right? So that gamma subunit has has intrinsic GTPase activity, and therefore, when the alpha subunit is released, there's only a matter of time before it cleaves the bond between GTP to GDP, and therefore it causes a reassociation between the alpha and gamma subunits, and then therefore we have the inactivation of the G protein. Got me? Next, receptor desensitization via GRK and BRStin, which prevents further coupling. Hold on 1 second, guys. Okay, let me see here. Okay, where were we at? Okay, and so here's how the signal is terminated. I think that's all we have for today. I think that's really reason I wanted to sort of use lithium. Okay, I hope that's clear for you guys. Okay, let's see here, and then let me know if you guys have any questions. Again, if you do, it's a pleasure. Otherwise, I'll talk to you guys later. Okay, take care, guys. Take care, guys.
Yes, here is our number and email on the screen. Just send us email or contact us through the cell phone. We also have a link down below there. Just click on that and you will be entering our clinic to see our own doctors. Thank you.